I really, in that setting, dealt firsthand with some of the perfectionism and how demanding physicians and other healthcare workers can be on themselves. How the weight of that kind of exaggerated sense of responsibility for their patients, that difficulty that so many have in carving out time and space for themselves and to take care of themselves. And then seeing the systemic parts of that, probably the selection bias starts, pre-med and then gets kind of carried all the way through because those kind of systems of training are not, particularly giving or forgiving of kind of taking time for yourself or setting limits or saying, no, this is a boundary. I'm not going to do this. And so I think then over all the years that requires kind of leaves people in a place where they're pretty good at being pretty hard on themselves, take a lot of responsibility for others' welfare and have a lot of difficulty kind of carving out some for themselves.
Welcome back to Flourishing in Medicine from Surviving to Thriving. I'm your host, Dr. Mick Krasner, and this podcast is produced by EmPro, a medical professional liability insurance carrier headquartered in New York State. We support physicians through educational activities as well as our peer support programs. Today I'm joined by Dr. Craig Rooney, a counseling psychologist, healthcare leader, and the inaugural Chief Wellbeing Officer at the University of Rochester Medical Center. His career has spanned private practice, integrated behavioral health, student health, and physician well-being, including helping to build one of the nation's early comprehensive healthcare worker well-being programs. In this deeply personal conversation, Craig reflects on the hidden emotional life of medicine, exploring three themes of grief, identity, perfectionism, belonging, leadership, and the search for meaning in a demanding profession. Together, we examine what it will take to create healthcare cultures where both patients and caregivers can flourish and not simply survive. So, Craig, before we talk about well-being programs, institutional leadership, and all those things, I'd actually like to begin much earlier with the human being who eventually became a psychologist. So I'd like you to just share with us what you understand now as to your why that moved you not into this position, but into psychology. Kind of another way of asking that question is, and I find this is interesting, who were you before the title of psychologist and why?
I grew up in the Midwest. I was the youngest of 4 children. My father was a Methodist minister, my mother an elementary school teacher. And so, we grew up, it was a modest beginning. My sister was the only girl and in some ways, had a little bit of a different trajectory kind of based on that. I followed older brothers who were very, very mechanically gifted and inclined, taking apart radios and putting them back together and those kind of things. And as I came along trying to emulate my brothers, I learned, quite painfully several times, I did not have that kind of manual dexterity that they did. So they would put together model airplanes and I would, go crying to my mother with my fingers glued together. All the boys in 7th grade took wood shop and they loved it and told me how cool it was. I was so excited. I went in, I struggled to get through that semester and got a D. So I was getting these kind of early indicators that I wasn't going to be skilled in the same ways they were. One went on to be a veterinarian, one went on to be a dentist. My sister went on to be a broadcast journalist. And so I was kind of trundling along after those 3, trying to kind of figure out, what I was going to do. And really learned early on I was just more relationally skilled, was able to kind of establish and maintain relationships pretty easily. And so, when I finally discovered there's a field for that, it's called, psychology, where you get to kind of connect with folks and, through that rapport and the maintenance of that relationship, make kind of magical things happen. So that's a little bit of the backstory as to kind of how I ended up where I did.
So I'm gonna share something that maybe out of left field, perhaps, or maybe it just has to do with a little bit of shame or wounding from gluing your fingers together, as you described. But there's an old idea in with us in healthcare about the wounded healer from Chiron, and this tradition, and that people are often drawn to healing professions because they've encountered some kind of suffering or fracture or longing. And I just wonder if that also resonates with you at all.
It absolutely does resonate. I, felt that early difference from my brothers in terms of, things like mechanical ability. But as I got into adolescence, also began to sense the difference from my brother in that I had these same-sex attractions to, other boys my age. And so, it was a different time. This was still the 80s. And so I was, kind of lodged myself deeply in the closet. And it would be many, many years, and not until I got to university where I could begin to sort that out. And so that was a lot of suffering, and that was kind of missing out some of the normal kind of developmental milestones of adolescence. And I think was drawn to psychology and psychologists because they were the folks at that time, then early 90s, who were really saying, yeah, gay people are okay. It's society that has the problem, and so to begin to hear a message like that, something that kind of cut through my own cultural encapsulation of the shame and what that meant, really made that feel like a safe space and like a home. So a wounded healer for sure.
And you've provided psychotherapy in your psychological part of your career to hundreds of health professionals, probably many physicians, I'd imagine. Um, and I wonder what did your clinical work teach you about human beings in general, about physicians in particular, not that they're not human beings, and about institutions that outsiders, people that are not psychologists, rarely understand.
Physicians are human beings, and that's a yes, we know that's true, and people would intellectually say, well, of course that's true. But I think when you provide, psychotherapy to many, many, many of them, that's so evident in that many of the problems that they bring into therapy are the problems that people bring into therapy. A lot of depression and anxiety, sometimes other more serious or persistent mental illnesses, sometimes medical diagnoses that they're struggling with. But I really, in that setting, dealt firsthand with some of the perfectionism and how demanding physicians and other healthcare workers can be on themselves, how the weight of that kind of exaggerated sense of responsibility for their patients, that difficulty that so many have in carving out time and space for themselves and to take care of themselves. And then seeing the systemic parts of that, probably the selection bias starts, pre-med and then gets kind of carried all the way through because those kind of systems of training are not, particularly giving or forgiving of kind of taking time for yourself or setting limits or saying, no, this is a boundary. I'm not going to do this. And so I think then over all the years that requires kind of leaves people in a place where they're pretty good at being pretty hard on themselves, take a lot of responsibility for others' welfare and have a lot of difficulty kind of carving out some for themselves. So it was a real honor and a real gift to kind of be the person in the place to help folks begin to unpack some of that. And there were pieces that were surprising in terms of the training, physicians don't get. So I worked with a lot of grief and loss of physicians and APPs grieving the loss of patients. And the striking part of it was just that, some of them, I remember one who came in and there had been, 14 patient deaths over a period of 12 months. And, she said, but I'm not family to those people. That's not my grief to have. So even the process of having to give permission that sure, it's your grief to have. You became a really important part of their life. And if you're grieving them for whatever reasons, they became an important part of yours. But there was they'd received no training, no, kind of preparation for what it's going to be like to be right next to trauma and just really sad situations and what it's going to be like to carry that cumulatively over weeks, months, and years. And so, burnout, to use the word that's talked about a lot, occupational distress, just that when they found themselves in a place where the math was not working, there was very little kind of in place, both in terms of their internal thinking as well as sometimes, environmental supports to take those breaks, to do that work, to feel okay about doing that work.
Well, you beautifully articulated, a whole series of aspects of challenges that physicians in particular experience, other health professionals as well, coming from really your one-to-one work in a lot of ways that sensitize you, and then bringing that into this new part of your career, which has been going on for quite a while. I know in terms of a leader in well-being. As you look back on that and with the work you're doing now, I try not to do this, but it's kind of a two-part question because it will make sense in a second. What kinds of things break people, we could say, in medicine? And then the flip side is, and what seems to restore them? So you can take those together, do one part and then the other, however you'd like to address that.
When we talk about the occupational distress of physicians and other healthcare workers, sometimes they can be the big things, the kind of repeated exposures to trauma with little preparation for the fact that there are no human bodies designed for this kind of repeated exposures to that without some kind of intervention. So I think it's the big things that can eventually break someone. There's so much of the death by 1,000 paper cuts kind of concept, the increasing, administrative burden and the just kind of daily frustration with all of the environmental irritants that get in the way of a person whose kind of value orientation and skills training is around patient care. All the, that 1,000 things that kind of pull folks off of and away from that. And again, the kind of cumulative effect of that. There is the potential for, I'm not saying, nothing I'm saying is about every individual, but there's a huge potential for this kind of isolation and loneliness involved in the work, even though, you're around people every day, that, healers and other healthcare workers are in very prescribed roles, and that role often doesn't involve kind of a real-time authenticity and vulnerability. It involves kind of wearing the armor and playing the role. And so that can be really, really isolating to people. And when they carry that kind of mantle, for a long time, they may not even really kind of know how to let down and connect and reach across that isolation. I talked to a lot of frontline clinicians, and I'm surprised at how many will say, I just really miss the days when another clinician had to pick up the phone and call you. Because even though there's more efficient ways to, shoot the message off, like I don't have peer-to-peer conversations with anyone anymore. And I've done a number of programs that bring clinicians together, and they'll try to do various clever, curricular ideas in them and things. But inevitably what comes back is that the most valuable part of those programs is the cohortness. It's this time to spend with peers, particularly across specialties and subspecialties, people they don't run into in the ecosystem and to talk to, because so many light bulbs go off. I'm like, oh, that's why you all do it that way. I thought you were just doing it to, mess with me, or, so they have these opportunities for connection and empathy about, the structures aren't exactly the same, but just to have a deeper, richer understanding of those things. So what makes, people whole again, and I have a professional bias, but I think it is that connection. I think it is the opportunities for, vulnerability and humanness to not have to be in an elevated expert role all the time. I certainly think institutionally we can help by trying to remove as many of those irritants as we can to get people back to kind of values aligned and being caregivers, because that's where that's what most people want to do. It's just to be able to do your work and do it well. So as many things as we can kind of get out of the way so people can do that. And that's challenging in healthcare. That's why I think all of us are hopeful for the promise of things like ambient AI. If we can get to a future state where, the documentation and even some order sets and things get, kind of teed up for folks. And early data, suggests that even when ambient AI doesn't necessarily reduce the hours in the day, most clinicians report a more valuable day because they're able to kind of look clients in the face, patients, eye to eye in the face again, and just spend that time on things that are a value add instead of, a detractor. So, I'm big on meaning, connection, purpose, and all the things that kind of facilitate those things happening.
Yeah, no, I really appreciate you bringing up, especially connection as this part of the restoration, because as you alluded to earlier, you're in a work life where you're interacting with people, but there is a sense of isolation. I've absolutely agree with you, having experienced that myself and knowing that my colleagues experience it well. You did earlier also briefly, and we'll get more into it, allude to systemic drivers and responsibilities. So I'm going to say something perhaps a little provocative, but consider this really that some small part of it might be true. And just want to hear your thoughts about it. It's posed as a question: do healthcare organizations sometimes ask people to be resilient in environments that are themselves injurious?
We have a couple of decades of the levels of occupational distress of, healthcare workers. And so even the least curious mind has to ask what's going on, on there, what's happening. I have never liked the term resilience. You often won't hear it come out of my mouth or see it in our programming a lot, just, because it puts so much onus on the individual, and it often assumes there's a lack of resilience is a part of the problem. We know from data that, among healthcare workers, we have, the most resilient workforce that there is. But again, no one is superhuman. Everyone is still human. So even the most resilient person will break under the right environmental, context. So that said, I am certain no one, set it up to be injurious. I think it's evolved in a patchwork over time.
I'd like to kind of explore the shift further into the institutional leadership domain and role that you have and kind of areas in which you work. One thing to just consider: what happens when a psychologist moves from the consulting room into organizational leadership. And when you come into that role, especially in a big way, as you have, the inaugural Chief Wellbeing Officer at our wonderful University of Rochester, how do you prevent a well-being office from becoming just a Band-Aid over systemic dysfunction? And I'm sure it's something that you worry about and struggle with and had to probably think about before accepting a position.
I think you try to set the direction and set the investments in the things that are, real fixes rather than to Band-Aid approaches. That said, enhanced workplace well-being means a lot of different things to a lot of different people. And so, our office was scoped across all faculty and staff. Some, well-being outfits are, for one part of the organization. And while philosophically, I think that is the right approach, because you can't raise some boats in well-being and not other boats. The jobs are all too interdependent. So you've got to try to raise all boats. But that, for different, parts of the workforce, interventions and meaningful programs are different. And so I think I had to get good with, it's a multifactorial problem. We're going to put out multifactorial solutions, and not all of those are going to connect for everyone. And some parts of the workforce might think this one's a Band-Aid, but for another group, it feels more substantive than that. And I've got to learn to just kind of be okay with that. We're attacking this from a lot of different angles. And again, people need, different kinds of things. So there's a huge range. When we talk about administrative burden and workflow inefficiencies for physicians, that's, a highly technical or nuanced and involved set of problems that needs, solutions that are equally highly technical and nuanced to try to solve them. If another part of the workforce is having a leadership problem or a lack of a sense of community. And there's a fair amount of that now. When I did my listening tour when I first got here, the biggest thing that was coming from all over the place was, how do we create a sense of community post-COVID? We now have all all this, Zoom and Teams and remote workers, and how do we do that? But so that kind of intervention might go to, foster and facilitate social connection opportunities. Well, again, for some parts of the workforce, that's going to seem fluffy, but for other parts, that's what's needed. So I think, like all these things, you try to assess and survey your workforce, figure out where there are gaps, begin to plug multimodal, kind of solutions in, and just know that they're not going to serve, everyone all the time. People will have very opinions about it. And then you always have cynics that no matter what you do, think it's all window dressing and, not solving the problem. That part as a psychologist leader is tough.
Yeah, I would think so. One thing I'm really appreciating about you and about your story is coming in with a certain level of humility, in that not coming in saying, I have all the fixes and the answers, but you described the first thing you did was listen. You went on this listening tour. And I think that's the right thing because, yeah, it's a big ask. And there's a lot of different constituencies, and they're all experiencing the workplace differently. So it's not a one size fits all. And then you'll really just upset people, and you just try to do what you can. I'm going to circle now back to this territory that touches on identity and culture, as well as how that informs leadership, meaning, moral complexity. And if at any point you want to steer more toward leadership because it's more comfortable rather than personal experience, that's totally fine. We'll start with just, how do you think about well-being in relation to inclusion and belonging? Like, are they inseparable? Are they parts of the same thing? What is that relationship?
Yeah, I've always seen, in my own mind there, the Venn diagram that has a healthy overlap there, because depending on who you are as an individual and the identities that you're bringing to work and the kind of relative safety or privilege or comfort of those identities or not, that's going to directly affect your workplace well-being. And so, if well-being efforts can't or won't be aware of those things, and when possible, try to address those things, then that's an act of exclusion, itself. So I've always felt like there's an overlap, and I have felt like for folks who work on inclusion and belonging as the core meat of their day-to-day jobs, I've always felt the most kind of simpatico with those professionals and organizations, in the same sense that you're tasked with addressing a problem that is much larger than yourself and is not fixable or movable without everyone across the enterprise, owning some part of it and agreeing to move it forward. I mean, these are not offices that can come in and sprinkle magical fairy dust and fix these problems. They're problems that have to be looked at across the board. So it is a part of it. And all of us bring our professional identities, which are, representative of some set of values and skills that brought us into the very, professions of choice that we chose. And so if that's a values driven and an identity driven proposition, and that I'm in a work environment where I can't really connect to and exercise, those values and that identity, we have a problem. There's been a lot of tension, understandable, in this space around, what an individual needs to do and what the organization needs to do. And I think this started in kind of resilience, and it started in, do we have adequate mental health supports? And, and I think those pieces are really, really important. I think there was a very understandable kind of reaction to that, to say, hey, wait, this is like giving CPR to the canary in the coal mine. That's not going to fix the problem. The problem's the mine, the toxic mine, and so we kind of swung to we've got to really hold organizations accountable. We've got to come up with institutional fixes for occupational well-being, which I'm in 100% agreement on. And a primary focus of our office is there, because this is the office that has to be accountable to do that, and other folks in other places in the organization can't do that. But that said, philosophically, I repeatedly am a both and person. That for a given individual, it's got to be both and, because that is the nexus of our identity, of our values, of our health, that ultimately ownership of that is going to be best directed, from ourselves. So I try to present those as a both and. I think that stems back to my own identity and my own process in those years of coming out and kind of dealing with my sexual identity. There was the, things I really wanted the world to change. And then there was the question I had to ask myself of either while that work's happening or if that work doesn't even get there, can I find happiness and joy and connection and health? And so again, that's a space where I have to, work in the interplay of that tension of, very much wanting the world to change around that and having to do some things to try to change the world and own a piece of that for myself so that I don't leave myself in the position of needing that to happen before I am kind of fully connected to my own kind of healthy sense of self.
I'm thinking, as you well know, that we live now in a moment where conversations around inclusion, belonging, diversity have become so politically charged. And I wonder just how do you personally, and then in your role as a leader, how do you hold on to the human dimensions beneath all that rhetoric and all that discourse?
I try to do one exercise that was kind of different than I was before. I used to, stay really abreast of things, and now I really try to limit my media consumption and not to put my head in the sand about certain issues, but to not be in the play-by-play of vitriol around it, and focus more immediately on my community and my work community, because those are the places I can have bidirectional, conversations and interactions with people. And that's usually where I find that people are at their best or better than in all the noise out there. And so I just really, kind of invest locally. But I mean that, emotionally, interpersonally, locally with folks that, I can, have conversations with and see if we can get to greater understanding and see if we can find what we agree about. I mean, I really think that's how civilization works, if it's going to work. So I've just kind of just shrunk the sphere.
So I'm really appreciating a couple things about our conversation thus far. There's an expansive kind of almost poetic nature to it. And I'm thinking in terms of humanism and philosophy. And so let's just continue on in that. This is kind of a philosophical question, I think. What does it mean that this role of Chief Wellbeing Officer, it's not in a healthcare insurance company, it's not in a manufacturer of products and services for healthcare, it's in a university. Just what does that mean to you to be, just when we think about what's the idea behind a university in general, and then for the university to feel that this is kind of a responsibility and an expression of their, raison d'etre, yeah. How do you think, what do you think about that?
Universities have, primarily been my own in my adult life. I had a, brief stint in private practice, but I think there is just something special about a place that is built around, the exchange of ideas and the value of ideas and looking for, evidence for ideas. It mirrors the, CBT work I did in therapy, which is that, it tests the veracity of these kind of thoughts in your head as opposed to kind of just listen to them. So I think that exchange, that it's really philosophically kind of built on a concept of discourse, has always been really, really attractive to me. And in academic healthcare, which in spite of the things about it that can be frustrating to people, I do believe is a values proposition. I think it is. And I think that there is often more kind of values, kind of convergence than divergence for folks, that most people really care. They care about other human beings. They care about helping others and bringing about healing to the world. And while we have very, very different roles and responsibilities in that kind of ecosystem, I think the place is trying to do that. And then we've got this educational level too. We're trying to train the next generation of caregivers, and we are doing the research, creating the innovation. So the whole thing, I mean, Meliora, our motto here is ever better, and I feel like academic health is about trying to make things better.
I sometimes think medicine has become extraordinarily technologically sophisticated, and yet I worry that it's becoming spiritually, philosophically undernourished, we could say. And I'm wondering, one, if that resonates with you, and if so, how could that inform your idea of yourself as the Chief Wellbeing Officer and the way you approach the job? Or could that inform the way you approach the job?
I'm always looking for ways to try to be facilitative of people connecting with their why, connecting with their purpose. So all those kind of lofty things I was just talking about, I think they're there for a lot of people, but they've either been kind of calloused over or gotten buried, or they're just easy to lose in the day to day. All the thousand paper cuts that are being pulled in a lot of different directions. So I think soul, the spiritual soul, I mean, comes from when we have moments that we can kind of recenter and reflect and be in touch with that meaning and purpose. And so I think the sheer busyness of it and the demand for it makes it challenging for the people doing it to connect to that. And so there's no quick and simple way to do it. I mean, one of the little things we've done is, this moment of why, and I have to credit Steve Witt, who's the CMO at University of Missouri. But it's, in regular meeting groups that you're going to see people. And even though we've all got a lot of work to do, that, on a rotating basis for the first 10 minutes, somebody comes and shares their moment of why. Because I just, you learn so much about people. You could have worked with them for like 10 years and not know it's about them. So it's to peel that back a little bit in the midst of all of this, so I can know your why and maybe see pictures of your kids and just know you as a little more as a human. And so then that second part of that meaning, I think, just to facilitate any moments where people can kind of connect person to person. If it becomes too busy and too cluttered to do that, then I think people are in trouble.
Kind of coming to the final part of just a couple of things I want you to think about and share. The first would be, what gives you hope right now in the work that you're doing and with our organization? Because I'm part of it, so I'm interested.
I think when an organization has reached the point that they kind of make the investment in that kind of speaks to some organizational readiness. And it also means that that organization is past the place of needing to be convinced that there's a problem. And so, like so many of our, healthcare specialties, we can't address a problem that's not known or, isn't, kind of stated. And so that makes me hopeful. And I truly know that most people, I believe, really do care about this now. And most leadership really, really cares about this now. I would have a hard time, working for a place where I didn't feel that was true. And I believe that that's true. So, for a lot of years in this area, it's kind of convincing a place. And then, once people kind of say, oh, I see it. Yeah, it's a problem. We need to do something about it. Now you can shift to the work of like, oh, okay, then what do we need to do? And so I'm really hopeful about that, because I think already good things are beginning to happen. And it just, I'm in a position where, even as other things are talked about, I can say like, hey, I wonder how this is going to affect our workforce or something more direct. Like, I think this, can have really deleterious effects. How can we, work with that or mitigate that? And I'm also not the only, voice in the room. And that's, raising these kinds of issues. And that's where I'm saying I know a lot of people care about it and a lot of people are committed to it. So the hard work's yet to be done, which is, how do we change such a large enterprise, and in general has a lot of problems in our country and a lot of regulations, a lot of tentacles in it, right? So then getting to, okay, how do we begin to kind of unwrap this and do a better job of taking care of our folks?
Well, your answer is very reassuring to me and hopefully to our listeners. What worries you most about, not your institution, because I don't want to know about that, but what worries you most about future of healthcare? Because there's a lot to to concern about our listeners, who are all in healthcare mostly, not all, that was not correct, mostly in healthcare, are worried about that too. So just interested in what worries you most.
I think it's a really complicated, nuanced enterprise to try to take care of people, to try to heal. And I think to, do it, we need a community, a political structure, just in our country where we can, have conversations about the best way, to achieve those objectives. And I worry, as you pointed out kind of earlier, in this conversation, there's a lot of side taking and an erosion of kind of our ability to just have grown up conversations about things. That worries me because there's no simple fixes to healthcare. It's a big, complicated thing. So I think it's got to really require some real honest iterations and conversations about it. And I worry, but I'm hopeful we can have those conversations, because I think to have it work is going to require it.
If you could whisper one thing into the culture of medicine right now, and the culture would listen and respond, not as an executive, but as just a human being, what would you say? What would you want us to remember? If there was just one thing you could just whisper, and remember this.
You are worth being taken care of too, and you can only do so much.
Thanks so much, Craig.
Yeah, you bet. Thanks for having me.
Thank you very much for listening. We will include a summary of today's podcast and links to Dr. Rooney and other related links in the show notes. I'd like to conclude by sharing another practical exercise to help you flourish. So let's begin by taking a few moments just to settle in to sitting or standing, however you are, being comfortable with your eyes closed or open. At one point in the conversation, Craig Rooney spoke of how he curates or pays attention to the media that he reads and listens to with awareness, and makes decisions based on that, of what he will take in. Quite often we habitually enter into the flow of much of the messaging that surrounds us without awareness or intention, operating out of our automatic pilot mode. To shift this and ultimately have more control and power of what we take in from our environments, we can begin at the starting point with the self-awareness that comes from paying attention to the activities of the mind. So settling into this moment, standing or sitting, for perhaps a few seconds of silence, and then noticing what specific sensations, thoughts, feelings arise. Take center stage, however briefly, and then move on to something else within your field of awareness. Simply noticing that. In this way, noticing how you can make a choice to either simply notice what is present rather than being pulled into the vortex of those thoughts, feelings, and sensations. This is much easier said than done. Try practicing this simple exercise for 15 seconds, half a minute, a few minutes, at any time, to reset your awareness and then be able to make the choices you'd like to make. I hope you found this podcast and this guided contemplation useful to you, and look forward to having you join us for the next episode of Flourishing in Medicine, From Surviving to Thriving. To learn more about EmPro, please visit www.myempro.com. And to learn more about EmPro's peer support programs, please visit www.myempro.com/peer-support. If you're a physician or medical student in need of urgent support, please consider calling the Physician Support Line at 1-888-409-0141 or visit www.physiciansupportline.com. Look forward to seeing you next time.